Welcome, everyone, to today's Schwartz Center Compassion in Action webinar, Inclusive Healthcare, Caring for Vulnerable Populations. Thank you so much for joining us. I'm Julie Collier, Senior Director of Programs here at the Schwartz Center. As many of you know, we are a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. Our vision at the Schwartz Center is that everyone who provides and receives healthcare experiences compassion. Before we begin, I'd like to share a few details about what you can expect. Please note that the program will last 60 minutes with a panel discussion for the first 40 minutes or so, followed by some time for questions. Feel free to enter your questions in the Q&A pane throughout the discussion. I'd also like to acknowledge with gratitude that this Compassion in Action webinar series has been funded in part by a generous donation made in memory of Julian and Eunice Cohen. With that, I'll hand it over to Dr. Michael Gustafson, Schwartz Center CEO, who is excited to get the conversation started.
Thank you, Julie, and thank you everyone for joining us today. At the end of last year, we had the pleasure of celebrating three amazing individuals as our 2024 National Compassionate Caregivers of the Year honorees. In fact, our competition for 2025 has already opened. And so today we really would encourage folks to think about colleagues or your providers, caregivers, friends who would be great candidates for this national award. You can check out the information here or on our website to learn more. The deadline is March 14th. Our three honorees this year work tirelessly with our most vulnerable populations, bringing dignity and healing to patients facing traumatic physical injuries, substance abuse disorders, end-of-life care, and homelessness, among many other challenging scenarios. It's my great pleasure to introduce our three recipients now. So starting first with Eric Garcia. Eric is an internal medicine physician in the Worcester Healthcare for the Homeless in the University of Massachusetts Medical Center in Worcester. Welcome, Eric. Secondly, Sylvia Parker. Sylvia is a geriatric nurse practitioner from Optum Healthcare in Wallington, Connecticut. And third, Xing To, a licensed social worker and workers' comp care manager from the Shirley Ryan Ability Lab, which is an acute rehab hospital in Chicago, Illinois. So welcome to all three of you. I'm just so thrilled to have you on our panel today and to share just a little bit about your amazing stories with our audience. So today's session is entitled Inclusive Healthcare, Caring for Vulnerable Populations. So I thought I might ask you just start by telling us a little bit about your current role as a frontline caregiver and leader in the vulnerable populations that you take care of on a daily basis. Sylvia, maybe we'll start with you.
Yes, hi. Thank you so much, Michael. So I am a geriatric nurse practitioner, and I work only in the nursing home population, taking care of elderly patients there. And I travel between several different facilities and really attempt to coordinate care, trying to be as proactive as I can, but also I do a lot of additional work within with my colleagues on terms of training and supporting advanced illness discussions and goals of care. So it really is truly my passion in that regard. So I really enjoy doing it.
And I know you do work around palliative care in Connecticut,
Yes.
Rhode Island.
Yes,
Yeah.
I do.
Ashley.
Yeah.
Thank you. Eric.
Hi, I'm Eric. Thank you again for inviting us. This is really an honor. Thank you. I'm an internal medicine doc through UMass Medical Center, UMass Memorial Health, and I work with an absolutely fabulous team of folks on what's called the Road to Care Outreach Van, We do street outreach to soup kitchens, parking lots, shelters, AIDS Project Worcester. The primary focus was to be substance abuse care for people experiencing homelessness. But it's so much more than that. It's sometimes caring for chronic illness that people won't get care for elsewhere. Sometimes it's literally just accompaniment. A lot of wound care, unfortunately, with some of the adulterants and the substances people unfortunately have addictive illnesses to. Um, but but a really wonderful supportive team that I work with, and that has been really a sustaining part of the job.
Thanks, Eric. And I know you guys recently started a medical respite program. You might mention what that's about.
Oh, that's been really fantastic. I just got back from there earlier today. Dr. Bebu obtained a grant for us to provide a respite, a rehabilitation facility for people who are hospitalized and homeless and find themselves in the hospital for tremendous periods of time because there's no reasonable place for them to go. And so part of our charge is not just to care for people and help them recover, but also to fund them housing.
Awesome. I know there's huge need there. And Zing, can you tell us a little bit about your work?
Yes. Hi, everyone. My name is Zing, and I've worked with the Shirley Ryan Ability Lab for 26 years. And so most of my social work career has been with this organization. And for the first 10 years, I worked as an inpatient social worker, care manager on the traumatic brain injury and stroke service. And then following that first 10 years, I did coverage service for all of our patient population in-house of the entire hospital. So including pediatrics as well as adults with physical disability and cognitive disabilities. A little over 2 years ago, I assumed a new role and as a workers' compensation care manager. Currently, I provide care management services to our injured worker population, including patients who underwent limb amputation due to work injury, severe burns, brain traumas, spinal cord injury resulting in paraplegia and quadriplegia. And I service this population in the outpatient basis.
Excellent. Thanks, Zen. I wondered if we could start today by just telling a little bit about what brought you to healthcare. Like, what part of your personal journey, your life, that inspired you to get into this line of work and to be in a setting where you can provide compassion on a daily basis? I'll let one of you, does somebody want to jump in?
I'll go, Michael. I really came to healthcare by way of watching the way healthcare was being delivered to, at the time, my grandmother. I was an artist. I went to art school. I did photography and really did not go into healthcare until my late 30s. But I watched my grandmother in a hospital, and I watched the care that was being delivered to her. And I remember observing and listening and thinking, surely somebody could do this better. And it really came about by watching some of the questions being asked of her. And I think this really hit home with me as an American Indian, that they were asking her very specific questions that she would have never known the answers to. And I thought it was odd that these healthcare providers who were treating patients in southwestern Oklahoma didn't have any knowledge of Indian people, Comanche people specifically. So in that moment is when I think I felt pulled almost towards healthcare, and thinking that I wasn't someone who went to college. I didn't take a lot of sciences, although I enjoyed it, but I was really motivated. And that it was that experience with her that brought me to healthcare.
That's an awesome story. Thank you. Zing, do you want to share it?
I'm sure I'm someone who's sort of never know what he wants to do when he grows up. So I'm I'm still growing up. And prior to entering the field of social work, my past trainings professionally have been in mechanical engineering, um, accounting, business administration, as well as theological studies. And it was the impact of the AIDS epidemic in the 80s that led me to healthcare field. During the early 80s, is those of us who lived that long, can remember how that epidemic impacted so many lives. And during the early years of that epidemic, while attending theological school in Chicago, I saw how a national health crisis impacts such a large community of people, a marginalized group of people, which led me to volunteer for an AIDS relief agency on my own, who provided assistance to those who were living with HIV and AIDS at the time. It was a tiresome and stressful few years of volunteering, seeing how so many of my new friends that I met through this work slowly wasted away due to the lack of treatment and access of treatment, while they've been discriminated against, uh, and helping them is quote unquote is a buddy to several of my close friends who I came to know well through those years. And despite of so much grief and losses during those years, I found purpose and meaning in that kind of work, and was empowered by witnessing how a community came together and stand against discrimination and care for one another with with quite limited resources. And we lean on each other for support, and do what we can to relieve the suffering of those who we came in contact with. And seeing how quote unquote natural it was for me to be in that context, several of my friends suggested that I should consider to become a social worker. And so I listened to their wisdom and went back to school and got my master in the field, and that which led me into healthcare. As a result, to practice what I've learned in my study as a social worker.
Well, you had some smart friends, so I'm glad that they pointed you in that direction.
Well, I think, I mean, at the time I was questioning whether it was the right thing for me to do, going from engineering to business to accounting and now social work, do I know what I'm doing? So, so I guess they knew me better than I was. I knew myself at the time.
How about you, Eric? How did you end up in medical
Uh,
school?
for me, in direct contrast to Zing, when I was a teenager, I had a paper route, and about the fifth house in was Mrs. Davies. Mrs. Davies had horrible arthritis and was um, horribly incapable of ambulating. She could barely make it from bed to her bedside commode, and her husband was quite elderly, and they were both um, she really couldn't get out to the car. They had no access to health care, and he was sort of too frail to help her get up and get cleaned and just some of the activities of daily living. In retrospect, they had no visiting nurses there. They had no real support service. So every morning I'd stop my paper route and knock on the door and see how they were doing, and sometimes would get involved in healthcare for her. I didn't know a thing. I mean, I'm a teenager delivering papers, so sometimes it was just a matter of helping her onto a commode. Sometimes it was helping clean her. And sometimes it was just checking in to make sure that they were doing okay. But I guess the thing that impressed me the most was that having absolutely no medical knowledge, and the knowledge that my great grandfather had been a doctor, it just sort of hit that this was a really big impact without providing medical care, really just providing support and presence and an extra helping hand where one didn't exist. And that really was powerful for me. So I thought, man, could I do more? And then um, I became an emergency medical technician in the same town when I was 18, and then just realized that, yeah, this is something I really want to keep pursuing. And here I am many years later.
What an amazing story, Eric. Thank you for sharing that. That's just it's so telling. I think it's a good transition to what I wanted to talk about next, which is how each of you define or think about compassion. So as you think about your daily work, you're obviously being honored by your colleagues for displaying and delivering amazing compassion. But how do you personally think about compassion as you're dealing with patients and families? What does that mean to you?
It's funny, you mentioned the word compassion, and I actually had to Google it. I know that sounds insane given what I do every day, given what we do every day, but I had to Google it to see what Google had to say in terms of it. And the word pity was brought in there, and I thought, what a misplaced word. It really didn't seem to fit with anything that we do or anything that we stand for. Um, I think compassion is simply being the paper boy who knocks on the door. It's simply a matter of knocking and opening a door, and that door um, gives you the opportunity, the permission sometimes to help. And I think that nobody, I'm sure none of the people who are listening right now don't know that feeling of, hey, I did something that made someone feel a little bit better, or that made someone smile, or I paid for the guy's coffee behind me before he knew it and I left. And I think that's compassion is a two-way street. It's not something that you just give. It also gives back. And I think that's, for me at least, why I've done this and been able to do it for so long, because you have to acknowledge that it is a relationship. It isn't just something that you give into a space. It's something that gives back.
Thank you for that. So
I would really just kind of support what Eric just said. And the thing that came to my mind initially is meeting people where they're at without judgment, and offering something of yourself. And Eric, as you mentioned, it isn't a one-way street. And I've always said that when I have students who work with me, and I always say, this isn't me coming in to save the day. There are times certainly that we as clinicians are going to, in our field, whether we diagnose and prescribe and whatnot, but there's an exchange that happens. And I feel, sometimes, students look at me a little crazy, but to me, there is a spiritual exchange that happens in that act of giving compassion and receiving compassion. I've had so many of my patients over the years, ones that have really advanced dementia, who you would think would not, remember me, but they always do. And it's interesting that here I am coming to see them, to, be present with them, and they'll stop me and they'll look up at me or look, just find my eyes, and they'll say to me, "How are you?" That is an exchange of compassion. And I think, and I remember when we interviewed for the segment that aired at the ceremony, I remember saying that we all can do this. We all can offer and receive compassion. every day.
Mm.
So well said. Thank you for that.
That's so true, Sylvia. I think to me, compassion is universal, right? Because it comes from us, each one of us have that potential, whether it is come natural, is part of our characteristic, or it is something that can be trained uh, as well. And I think that's universal because we all believe in the golden rule, right? We do unto others is it is that we want to be done to us, and so it is there's a mutuality there in an act of compassion where that compassionate caregiving is a relationship between two people. Perhaps professionally, we define as one is a healer and one is the wounded person, but it can be reversed so easily because it's only take one life crisis that the healer become the wounded. And so it is a relationship. It must be acknowledged that it has to be a relationship of equals and not just the wounded and the healer. And only that when we know as caregivers and healthcare provider, that we acknowledge our own limitations, um, acknowledge our own, in some way, darkness, days
Mm.
where we don't behave the way that we're supposed to behave with our patients, because of all the things that we perhaps dealing with ourselves, that unless we acknowledge that, it's very difficult, I think, to convey compassion in the caregiving that we provide to others.
Then thank you for that. I wondered, the Schwartz Center and our Schwartz Rounds is really based on storytelling. It's so important and the power of storytelling. I know each of you value that in your work and understanding the stories of your patients and your families. I wonder if you could just share a little story about a patient encounter or a moment with a patient that illustrated compassion to you, how you would think about it. If there's a patient that jumps out or a family.
I just want to tell a very quick story. And I always find for myself, for my patients who are in their 80s, 90s, 100s, when they pass, the way in which I keep them with me is by storytelling, telling a story about them. So I always want to write a book about my patient Doris. But this story about her, for me, I don't believe I could have ever received the highest form of a compliment than what she gave me that day. Here was a woman who was in her mid-90s, very hard of hearing, but I always had to pretty much yell to get her to know I was with her. And she had family, but I never saw them. And I would see her pretty much every day, sitting at the nurse's station, and I would always talk to her. So one day I sat with her beside the wheelchair she was in, and we were just sitting. We weren't speaking. And she was holding on to my hand. And at one point I had to leave. And I yelled pretty loudly, "Doris, I have to go." And she took my hand and she squeezed it even harder. She wouldn't let it go. I said, "Doris, I have to go." And as I pulled my hand away, she grabbed it and held it tighter. And she put her other hand on top. And she turned and looked at me and she said, This is what love feels like." And that to me was the greatest, most beautiful story, sentiment that I've ever received from a patient. That even in her progressive state of dementia could feel the love I had for her. And it's so emotional for me because she just died probably about 4 weeks ago. And she never had family come in. And I, at the time, was sick. I had the flu. I couldn't go in to see her. And I had a nurse who was with her. And he said to me, Sylvia, I think, you know, she's going to pass. So I wanted to make sure she had everything available for her in terms of meds, comfort meds. And then he called me back later and he said, you know, we got all the meds ordered. And I said, can I talk to her? So he put the phone to her ear, and I was able to tell her that when I first met her, she would tell me stories about her parents, about where she was raised and where she would go on vacation. And I said to her, Doris, it's okay to go. Go to that upstate New York, go to that pond, because your parents are waiting for you. And then an hour later, she passed. But that love she felt and the love I felt from her, I think allowed me to be with her even at the end of her life, even by just hearing my voice.
Wow. Sylvia, thank you so much for being willing to share that. It's a great illustration.
Very, very special moment to me.
Eric or Zing, I don't know if you want to follow that, but
I don't think any of us can follow that, to be honest with you, but I think there was one thing that touched me about that, and that was that no family visited. And I encounter that every day of my work, in that most of the people we see who experience homelessness have no support network. Many of them have no family, have no people. And so my story is very short, and it happened yesterday. I was doing a clinic at one of the shelters, and a guy named Mike called. We carry something we call the brick. The brick is each of us pass it once a week, and when we do our outreach clinics, we make sure that we have the phone available. Someone has the phone to answer questions, and the brick has saved lives. We've actually were able to locate someone who had overdosed, and it took a huge team effort to do this, but he was found before he passed. But anyway, Mike called yesterday, and I'd only met him once in October of last year, and he called me and he said, "Hey, I'm at Dimick in Boston, and I'm about to go in for detox now, and I'm planning on going into an aftercare CSS program, and I'm really hoping to get into a halfway house after that." And he wasn't asking for anything. He didn't need me to send records or medication or anything. He simply wanted to share something that was important to him. He simply wanted to say, this is happening in my life, and I don't have anyone to tell this to, but I have this phone number of someone who's on the other end who I think will care. And it took me a few moments to figure out why he was calling. And then I realized he was calling because he was happy. And he knew that whoever was on the other end of the phone would be happy with him. And I think that, you know, the guy who was dying in the hospital, who I snuck his cat in to see him. And I have to tell you, it's not easy to sneak a cat into a hospital. But I think the point being is that so often we find ourselves as the connection for people who don't have a support network, who don't have love in their lives, and maybe never have. And just providing comfort without the expectation of anything in return, I think is really important. And I see this on a very regular basis. My whole team does, really.
Thank you, Eric. Then I'm going to ask you a slightly different question, because one of the things I wanted to touch on was I know in talking to each of you and the folks that nominated you, that you guys bring so much positivity and joy and energy to the work that you do every day. I think, Zing, you're known for wearing Hawaiian shirts throughout the hospital and just being a beacon of joy and energy. So the question is, despite the challenges that you're working with your patients and their families, and in your case, these devastating neurologic injuries that the patients have had, how can you maintain that positive energy and that compassion?
I had supervisor when I was in training during graduate school that used to tell me that if your compassion does not include yourself, it is certainly incomplete. And I think that's a quote that from someone that is wiser than me, but it's something that I always have to remind myself each day on the fact that we also have, as much as I spend the energy and the commitment that I make to the patients that I care for each day, I also need to do the same for myself, because we cannot really quench the thirst, right, of others when our cup is empty.
Right.
And I think for us, for me, it is a daily commitment. It's a daily struggle on knowing how to do that, knowing when to respond with a compassionate no when the avalanche of requests keep coming. And they say as you work in a hospital, it's open 24/7. So the needs are always there, and you can literally work 24/7 if you want to just meet the needs. And so I think for me, that's a struggle, and I do that. Sometimes it's just a matter of taking a moment to return to the breath, because for me, sometimes the rush of every day, I forget to breathe. And then going into the exam room with the patient and have my mind somewhere else versus actually be fully present, to offer non-judgmental listening to the patient when they speak about their needs. So sometimes it's just a matter of before opening that exam room door, I close my eyes for a moment and then remember to go back to the breath and just to know that for that moment, I'm there for that person versus taking care of so many other things that it demand of my time and my energy and my attention.
Well, you've touched on several really important points there, including like responsible boundaries, right, to protect yourself and centering on the moment for patients. So, Sylvia or Eric, do you have any other thoughts here in terms of how you maintain your joy?
Well, you just saw one of them. Steve. Steve is my dog. It's sad, but I did mention him before my wife and my kids, who I'm going to fly out to see my daughter right after this. Point being is just balance and staying connected to the things that fill your cup.
Yeah.
Yeah, I would say, Michael, that I have personally struggled with separating myself from my job. I always felt that what I do is what I love. And what's the famous quote? If you love what you do, it's not work. But it is work. And I think a lot of people who know me were quite shocked that I stopped working weekends, because I would readily go in every weekend. And I tell people, these sick people don't take holidays, so. But at the end of the day, I also found myself not so much with my patients, but with staff, not being as patient as I should be. And I think some of that just came from constantly working. So I've taken up trying to teach myself how to bake sourdough bread, and then also learn how to do some leather work. So some of that is just me really realizing I needed other outlets for myself.
Yeah, awesome.
Yeah.
Well, thank you for sharing that, because it's so important, I think, to take care of ourselves or yourself so that you can take care of patients. Really
Right.
important. Each of you are in settings where you have an opportunity to teach others around care and compassion, which I think is really important, because some folks don't think that maybe compassion can be taught. Maybe it's just innate. It is what it is. You either have it or you don't. But clearly, I think through your work, you either teach formally or you role model communication and connection and listening. So I wondered if you could talk about how you think about that. Eric, I know you work with tons of medical students and residents.
The most exciting thing for me is now I'm working with the first year medical students, the early clinical learners, in a course that should be recalled how to be a doctor. It's not a lot of didactic. There's some didactics, but what I think is wonderful is the curriculum we've developed, the curriculum that we're teaching that has been developed by some really great minds, is so incredibly engaging. And I find myself being a better doctor simply by teaching people how to communicate, how to be respectful of someone's gender identity, how to be respectful of someone's sexual preference, someone's comfort with, a white older authority figure that they might be scared to see. And just recognizing that so many of the new students who are coming in are just wonderful people. I mean, we have these stereotypes of people like this on their phone walking down the road, not really connecting with others. I find just the opposite with the students that I teach and I model towards, which is that they're connected, they're sponges looking to just absorb as much of this as they can. And what I'm very fortunate is that my job is inspiring to them, which is kind of neat. And, some of them work in emergency rooms and are very inspired by that. Some of them not so inspired by, say, a nephrologist, but some really that hits the part of their brain that they really need stimulating. But it's just wonderful to be able to have a role that a student looks at and says to me, I think I want to do what you do when I finish this training. And unfortunately, the training and the realities of finances and the realities of life sometimes pull people away from their initial ideals. But it's really nice to make those ideals so clear in my work and to be able to convey that to them.
Thank you for that. And Sylvia and Zing, I know you teach other staff, your colleagues, role modeling.
Yeah, I have had students, a lot of students over the years. And I think one of the things I say to them right off the bat is, first of all, I want to know why they're here. Why are they going into this field? But then I really start off by saying to them that they're going to learn a lot about geriatric medicine in a nursing home. But the one thing I want them to take away from this experience is I want them to walk away saying, I learned how to communicate better. How do you communicate with a patient who's nonverbal, progressive dementia, who won't let you listen to their heart and lungs? How do we negotiate that? And one of the things that I've done in the training of like palliative care and advanced illness is I always ask my fellow colleagues, tell me the story. What's the story of this patient? Not that they have heart failure, not that they have, hypertension and AFib. What's their story? Because it's the story is what allows us to treat, to heal. And I always remember a patient of mine who's actually fairly young, who was in a nursing home. He was in his mid-50s, pretty advanced psychiatric illness, subsequent dementia. And I learned by his family that he used to work in plants, worked in a flower shop. And there were times where he was so combative and so people couldn't get near him and staff were afraid of him. And they called me and they said, you know, we got to send him to the hospital. And I went to the grocery store, bought a small plant, like a tree, small little plant, and took it to him and sat it in front of him and took his hands and put it in there. And this man was transformed. And had I not known his story, he would have ended up in an emergency room somewhere in a psychiatric inpatient setting, probably, who knows, you know, tied down somewhere, because he was incredibly combative. It's not that they weren't, he was, you know, getting difficult to manage. But that act, that knowledge of him was really able to turn his whole emotionality, the whole experience. And I remember the nurse is like, how did you know that? Well, I knew that because I got the story of the patient. And to me, that is when I have students is we can read charts, we can learn all that, but tell me about this patient. That's the communication part.
Boy, that's a powerful lesson for anybody that's that you're teaching and working with. So thanks for that. Zen, do you have any thoughts?
I think having empathy for others should move us to action to relieve their shared suffering, right? Because it's that's what compassion is about, is pretty much that we are suffering with somebody in that moment that we have the honor to witness their life. And um, I I think for me it's offering teaching maybe new social worker or just role modeling for others, you know, the fact that your presence is a gift and you must honor um, that gift and cherish the fact that you can provide that gift to another soul that is in your presence. And by doing so, you need to stay in the moment with them during our interaction, and also listening without judgment, not to follow an agenda that you may already have in mind when you step into that relationship for that moment, and be an observer and versus absorbing what is happening. And I think that's a skill by just not talk, but listen more. And sometimes I've had others who I have the privilege of train them at the beginning of their career. They say, you know what, by not using a template of how to do to evaluate somebody and have a conversation with them, as you say, that I listen to them and engaging with them for that first 15, 20 minutes of your time with them, I have learned more than what I can find out by firing questions from a template.
Yeah.
And I find that it's rewarding when you actually leave the room, when you spend time with your patient, knowing that you had cultivated a relationship versus just completing a task.
Those are powerful, powerful messages. I mean, the theme of listening is how you find out the story, right? The patient story, and that leads to what really matters to the patient in terms of goals and treatment and aspirations. So thank you for sharing that. I'm going to turn to a couple questions that we have coming in. So one of the listeners wrote, my question is, how do each of you see the patient's spirituality playing a role in helping them cope with their medical situation, and how their spirituality plays a role in their healing? Anybody want to tackle that?
I think for myself, I think it's so important to understand, where people are on their spiritual journey, and some people, one of the nursing homes I work in is a Catholic facility, and their religion is incredibly important to many of my patients there. Um, so it's also understanding how do these beliefs come into, again, for my patients, end of life. How does that correlate for them? And there's so many times where, they have a sense of peace about what they believe will be their journey after they passed. And then there are those who may not necessarily have a religion, but who have a strong spiritual belief. And I always find for myself, as an American Indian, I have certain beliefs about what happens when I die. And I'm always curious from them, what do you feel? And when we're dealing with end of life patients, some of those who are really, really struggling with either the act of dying, the pain of dying, saying goodbye, and that when COVID hit, that was a huge part of what I was dealing with. But it's so important to understand where they see themselves in that journey and asking kind of those questions. I think some of my struggles have been really coming to learn about other religions that I'm not familiar with, and how does that play out with how they treat. I deal a lot with families, but how's a family treating their loved one who may be nearing the end of life, and the decisions that they're making as it's based in their religion.
Absolutely. Thank you so much for that. Eric, did you
Could
want to
I?
add?
Well, not so much to that, but afterwards, I'm not sure. Is it Sumi? I wanted to handle her question at some point. She
Yeah,
asked early on, how do you handle situations where patients from marginalized communities may feel undervalued, overlooked, making them lose their trust in the healthcare systems? What do you do to build that trust? And I think that's I feel ill prepared to answer a question on spirituality and well prepared for that question, because the 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 answer unfortunately involves making up for a system that can't necessarily accommodate people who are experiencing homelessness or severe and persistent mental illness or substance use disorders. The standard system as it works would never stay afloat trying to meet the needs of people who, if you tell them they have an appointment at 2:20 p.m. 6 weeks from now, that's meaningless. When someone's life is chaos, um, telling them they have to be someplace in a period of time that they're not even sure they're going to be in Worcester, let alone Massachusetts, let alone alive.
yeah,
When you're living day to day, your life is chaos. And um, so I guess the answer to that would be multi-leveled, and certainly one level is establishing a relationship, letting people know that you're going to show up next week and the week after that, with no expectations of them other than to be present and have a mutual caring for their health. So you immediately establish a relationship because you may have very little, if anything, in common, but you have this one thing, which is we both care about your health. We both have this mutual desire for you to feel better by the time we're done. Um, it also has to come with a degree of sharing, you know, sharing with appropriate boundaries of yourself, letting people see who you are. And when people ask you questions, there are some boundaries are important. Some people only know I'm Dr. Garcia and I'm here Monday, Wednesday, Friday. Others, on the other hand, know the name of my kids. They know that it's my daughter's 30th birthday coming up. And that helps people to relate to you as a person and that you're willing to share as well. And I think, again, very early on, we talked about the importance of relationship, the importance of not just giving compassion, but receiving. And I think that's part of this. So I think respect, the careful use of humor, and the give and take of sharing this relationship with somebody and building relationship over time. We have many people who have horrible medical conditions and really need to be in an emergency room, but will not go. And so our job is not to make them go. Our job is not to coerce them to go. Our job is to respect that, do the best we can with what they'll permit us to do, but always with the knowledge that we're trying to advocate for the best possible outcome, and eventually may wind up helping them get to the emergency room.
Eric, it's so well said, and in terms of building that trust through that relationship, and it takes time. I'm sure that you've built that over time with many of your patients. So I wonder, I wanted to ask if, in general, a lot of folks would say today that our systems are just too complex, where it's too stressed, it's too overwhelming to be able to focus on compassion. And I wonder how you would react to that. How do you find the space, despite all of the things that are going on in healthcare that make it perhaps difficult to be able to focus on that? Is there one or two practical tips that you can offer to be able to do that?
But I think what Zing said this earlier about taking a breath. And I think for me, there's the stress of healthcare. There's all the other components to it, the charting, and all of that, the things that as clinicians we have to do. But I think for myself, I just really try to never lose sight that I am having a human to human interaction with another person who is vulnerable, who is looking, if I'm there to help because they're sick, or I'm there just to visit with them. My patient Doris, maybe I was the only person she was going to actually truly talk to that day. And I think for me, it's just maybe taking that breath and realizing this is the space in which I'm entering. And the easiest thing for me has always been being present with my patients. Nothing exists for me outside of them when I am with them. Mm-hmm. And I don't know, I mean, it has been the easiest thing for me. Outside of that room with them, it gets really complicated. But I don't know. I think that really centering yourself and going into that space. So I'm going to use Zing's techniques, but I think it's really just important to be present. And then taking care of yourself is such a huge part.
Yeah. Thank you for that. Zing, Eric, anything you would add?
Yeah, I think the acknowledgement that self-care is a birthright, is a caregiver, not something that we can earn or need to be earned, but it's something that we must do for ourselves. I'm still learning how to do that on a daily basis. And as I witness my colleagues, fellow physicians, nurses, and patient care aides struggle each day, I'm just inspired by them all on the sacrifice they make to do the work that we do every day. To me, at a macro level, I think organizations, lawmakers must think about how to change our healthcare system where it become more compassionate, less of a business, although that is important. I think the focus has been swinging on the other pendulum, on the other side, where we need to kind of bring it back a little bit more on the personal level, where physician can actually spend time with patient versus doing so many other things that they are required now to do. And I think as an organization, a healthcare organization, for those leaders who can impact healthcare practice, hopefully that they could somehow institute measure that could bring back that uniqueness of the relationship between the two people, the wounded and the healer, and the mutuality of that relationship, and also how we can support caregivers in their daily work, as stressful as it is now.
Yeah. Well, I think that's, part of the mission of the Schwartz Center is to try to really preserve and keep that relationship like central in healthcare, despite all of the other macro issues that are going on. At the end of the day, that will always be there. And so how do we strengthen, protect it, preserve it, build it is really, really our mission. So everything you said is resonating. Eric, there's a chat going on about hierarchy and teaching and strict. You have
Yeah,
thoughts?
I have a lot of thoughts on it, there was I think that one of the things that's wonderful about teaching now is that we're really trying to remove this sense of otherness between patients and providers. Remove the sense that we're somehow in this hierarchy of I'm here and you're there. And I think that's been going on slowly for years. And I think the internet has certainly accelerated that to a great extent. In that people often know more about their disease process than I do. And I have to acknowledge that and reassure people that I will learn so that I can get on the same page with them. I think that when we see people, however, using resources that aren't necessarily vetted and espousing ideals about things as simple, straightforward, and historical as vaccines, and questioning the merits and benefit of medical training, medical research, and evidence-based care, I think that becomes really difficult. And I think that it is at times difficult as a provider not to push back on that. And yet our usual answer, which is just sort of silently shake your head and know that you're not necessarily going to dispel a conspiracy theory, isn't necessarily the right answer either. So I think that I'm encouraged that our training now really does its best to try to remove this sense of us and them, and rather bring us together as a team in care. And I think that's the goal.
Yeah. Well, we could do a whole hour on that topic, I'm sure, or several hours. So any other final comments? I know we're almost out of time. Any other burning items or issues?
I just want to thank you, Michael, and just the opportunity to come together again to be able to have this amazing discussion. I think we could probably go on for hours and continue to share with each other and with others on the call. But thank you so much for coordinating this.
Thanks to each of you. And Julie, which means I think we're ready for our wrap up.
Yes, unfortunately, this has been such a wonderful conversation. I hate to bring it to a close, but we must. So thank you so much to our National Compassionate Caregiver of the Year recipients who have so graciously shared their wisdom today, and to all of you who joined us here. We hope you've enjoyed this Compassion in Action webinar. Please keep an eye on your email for news of future events. And as a reminder, we have opened up nominations for the 2025 National Compassionate Caregiver of the Year Award. And finally, please take a moment to fill out the very brief survey we'll be sending you after the webinar. We really appreciate your feedback on today's session. Thank you for joining us and for your commitment to compassionate healthcare. Take care and hope to see you soon.
Thanks, guys.
Thank you.